Hi, I'm Kaaren Mathias, and I'm working with the Emmanuel Hospital Association, a large group of hospitals with mission background across North and Northeast India, and leading the mental health program. And really glad to share in this webinar today about our community mental health work in India from a Christian standpoint, even in times of COVID. As a background, India is a place with very few resources for mental health. There's one psychiatrist per 100,000 people. It's also difficult to access care. It's a highly privatized system, and most of the 80% of spending is out of pocket by poor people. There's a high prevalence in disability related to mental illness, and there's just a lot of people, not much data, and really high prevalence of disability, as there is in most of the world. And COVID, as I showed in the orange mark there, is en route. We've nearly got 500 cases and rapidly increasing, and health services are really going to be very stretched. It's a very, very somber outlook. And in the middle of this, we ask ourselves, what are the guiding principles that we can use both in managing COVID and in mental health? And so I've listed these 5 here, and that's what I'd like to talk about today. The idea of asking and listening before leaping into action, I think is just one that's very sobering, because as mental health professionals and as health professionals, many of us leap in thinking we know what people need. Supporting access to care is probably a more straightforward one, and we know that there are many places where there is no care. Including people on the edges is something that for our program is really critical. It's a core message of the entire Bible, and very, very evident in the Gospels. And so social inclusion, addressing stigma and discrimination is really big in our programs. Caring for the whole person is a really clear message throughout the Bible, and something that we really try to attend to. And the kind of meta message that I guess all of us seek is that we can have life, and life to the full, as Jesus offered in John 10:10. So I'm going to go through each of these with some examples from our program. Just to start off, the main work that I'm speaking from is the project that I'm leading called Burans, which is the rhododendron flower. I've got the project vision written there. It started 6 years ago, and we work particularly in urban informal settlements or slums and in remote rural communities. The first principle that I wanted to talk about is ask and listen. And it comes from that story that we're quite familiar with, a blind man sitting on the edge of the road, calling out, Jesus, Jesus, son of David, have mercy on me. And Jesus calls the man and says, what is it that you want me to do for you? And I think many of us with a blind person in front of us would assume that what they wanted was healing. But I think it's really important that we don't assume, and that we ask people, and ask at a community level what people need. We use a lot of rural participatory appraisal methods. When we go in a new community, we do a really structured health assets and needs assessment so that we can build on what's there rather than bringing in some kind of sort of pre-made program. An example of this was last week. I was in a small town in North India, and a group of women, when I started talking about COVID virus, straight away pulled up their phones and showed me their WhatsApp concerns about an asteroid going to hit the Earth. And until we could talk about that and the fake news concept, we could only after that was I able to go on and talk about the importance of hand washing, and whether they saw their needs most urgently as food or infection control. We also just try to use that at an individual level, and use a very active listening approach with our community health workers, and develop care plans together with caregivers and people with psychosocial disability. An example of how we do this in a more structured way is we have an experts by experience group, an advisory group, and they have helped us in co-producing some resources such as a recovery tool, There's a video on this shown here, and we've also written this up in an academic setting. Very humbling, very difficult for me in many ways, and much better outcomes at the end than a group of professionals launching forth to say, we know what you need. The second principle I wanted to talk about is probably one that is most familiar to us. It's to support people to access mostly biomedical care. Given that there are only 7 psychiatrists in a state of 10 million people in the public setting, we really are focusing a lot on training primary care doctors. There's some really great WHO materials, MHGAP, and we also have to work really hard at the moment with the health system, which is already somewhat frayed in really greater levels of disarray with the current COVID setting, and trying to ensure access to medicines, particularly for people with epilepsy and psychosis. The third area that we're really working on, and that's been a very key theme for us, is including the people on the edges. And so we do that both in the way we select the communities where we work, in the way we select the staff who work with us. We try to have a strong representation of women, of people from oppressed castes, people with disabilities, people who are Muslim. We also do this by forming and supporting psychosocial groups, which are really a great way for building peer friendships. And we're also writing and researching exclusion and stigma and talking about these in the media and academia and civil society. So social inclusion has been a very strong theme, and it's obviously a really big issue in the setting of mental illness. An example of a program we did on this, we developed a youth resilience tool which had a strong focus on social inclusion, and we examined whether it changed the ways that young men who had mental illness, and particularly in this case people who were drug users, participated. At the beginning they were isolated from their communities. They weren't allowed into the Gurudwara or the Sikh temple, and these young men who have been happy to give permission for this photo to be used publicly, were then seen for the next 4 months participating in our psychosocial support groups and in lots of games and activities. And this gave them an acceptance in the community, and they're now allowed into the temple. Some of them have given up their bad habits, some of them haven't, but they are much more engaged, and we've written this up. I've given the paper there. The next area I wanted to talk about was the idea that health has to be more than mental or physical, and we're trying to look at spiritual health. In India, many people would first seek help with their religious leaders or traditional healers. And so we've done a lot of training religious leaders. We work a lot, and even now in giving COVID awareness, we're working a lot with the masjid or the mosques, and with the Hindu priests, and with the Sikh and Christian pastors. Really, in nearly all of the religious groups, the idea that someone with mental illness has an evil spirit possession is very widespread, and particularly with Christian pastors, it's been great to have some Christian psychiatrists who've been able to share about the symptoms and signs of psychosis and as well as acknowledging that there are spiritual dimensions to ill health of any kind. Physical health is obviously really important as well, and at the moment probably the most important work that we can do in communities is around infection control and hand washing, social distancing. We work also a lot with people with physical disability, and have done quite a bit of money on income generation as well, I guess, which is maybe more economic health, and also emotional health. An example of a group of young women who's done this was after we'd done our youth resilience program, they had decided they wanted to collectively take action against the large number of mosquitoes and dengue infections in their residential area. So they went around the whole community and got this petition signed. They took it to the city council, and amazingly, the city council was quite responsive, and within a few days came and sprayed the slum. And lots of people in the area came and started asking this group of 14 and 15-year-old young women, can you please sort out the toilets, and what about the water supply? And it was a very empowering process for them, and I guess help their mental health to work on a physical health area. The final and biggest goal is that we're working for abundance of life, and in John 10:10, Jesus says, "I have come that they might have life and have it to the full." And at the moment, things are really looking grim. I think all of us feel deep fear looking at some of the statistics on COVID virus. I think I'm trying to only look at media once a day because it's actually a little paralyzing. And yet I believe that the message that we have of grace and forgiveness and unconditional love is more important now than ever. And in our own homes and in our communities, trying to share that message of inclusion. There's a great word in Hindi, jugaad, which means kind of adjust and make things work despite sort of suboptimal circumstances. And this young boy playing cricket, I think, exemplifies that. And it's a very strong spirit of, can do across India. We work, this press article is the Director General of Health for the state who joined us on a World Mental Health Day. I think we need to work at multiple levels, but to listen attentively and to celebrate life that we have. And at the moment, with COVID virus, our main focus on is to provide people with companionship and let them know they're not abandoned, even though, our organizational policies of trying to protect staff is important, but we do have people working in communities who continue to be voice. So those are some ideas. I'm really happy to be contacted and talk more about work happening in community mental health in your area. Thanks very much.